care, in the sense that we avoid doing open surgical procedures. Patients do not need to travel abroad for these kind of things. It is a very exciting time for us. So when we talk about cryobiopsy, what is it? Cryobiopsy is a sorry, I can't see my slides.
Show this.
Yes, thank you. So cryobiopsy is one of the techniques which we use, which we call cryotechniques, and these include cryobiopsy, cryotherapy, and cryorecanalization. In summary, cryobiopsy is taking a small tissue which we can send to the lab for analysis so that you can identify the disease that is affecting the patient. Cryotherapy is a process where we use temperature, very cold temperature, to treat some conditions which may be in the airway by freezing them and therefore killing them. Cryorecanalization is a process by which we can open up the lumen, the obstructed lumen of the airway, so that, for instance, in patients with masses within the airway, they are able to start breathing well, or we clear the atelectasis, which would maybe a consequence of the obstruction of the airway. We also use these techniques, for instance, in patients who are bleeding within the airway, to get rid of the clots that may be obstructing the airway. Typically, the treatment consists of three components. The first is a console, and the console will be used to control the cryoprobe. It also tells you the kind of effect you are having using the cryoprobe. The other one is the cryoprobe itself, and this is a flexible tube which is long and has a blunt metal tip. And this blunt metal tip is cooled to very low temperatures, up to -89 degrees centigrade. And this is able to take biopsies at the point where we want to sorry, a technical problem. So the other part is the cryogen, and in this case, it is the gas which we use to cool the tip of the cryoprobe to the relevant temperature. Now, many times we have used nitric oxide, but lately we are using, in our setup, we are using carbon dioxide. Okay, let's go on. What's the history of cryoprobes? Modern cryoprobes consist of long flexible tubes, as I've mentioned, which have a blunt metal tip. The history is such that it is the neurosurgeons who started this thing, because they would use this effect to assess whether a part of the brain they wanted to operate on, what effect it had. And this was done before the operation so that they can predict, and if they find that the effect of their procedure is okay, then they can do the procedure without too many problems. The way we achieve a very cold tip is by using a principle called Joule-Thomson effect. And this is where we know that if a compressed gas expands, it tends to cause a very low temperature. And this temperature drops within a few seconds. Once the gas has expanded, then it flows back along the catheter and it is vented into the atmosphere. And cryoprobes have been used in bronchoscopy from the 1960s, mainly those days for cryodestruction of abnormal tissues in the airways. But later on, it was found that this same technique can be used to get a small tissue from different parts of the airway and also the lung parenchyma, and by holding the tube by cryoadhesion, then one can get the frozen tissue out. The advantage of this over the usual use of forceps is that we are able to get better samples, bigger samples, and we do not have the crash artifacts that we get when we use forceps. And if we look at the equipment that we use, on the left upper corner, that is the cryoprobe. The console is on the right upper corner, and you can see the size of specimens on the bowl on the right lower corner. We also use balloons, which help us to control bleeding by causing tamponade of the segment where we are taking our biopsies. And this is a useful part to use because frequently you get patients having bleeding, and if you are able to tamponade, then you can control bleeding easily. We will demonstrate how you practically use the balloon when we go to do the practical aspect of it in theater in a short period of time. When we are doing this procedure, it is important to be able to tell how far your cryoprobe is. You would want to avoid being too close to the pleura because that increases the risk of pneumothorax. And so we use fluoroscopy, and as you can see on the image on the left side, you can see the flexible bronchoscope, and protruding from the tip of the bronchoscope is the cryoprobe. Then one estimates how far the cryoprobe has gone, and then you try to move it away from the pleura so that you don't cause pneumothorax. Especially if you are using very, like a 2.4 millimeter probe, you need to be very careful because you may not tell when you have reached the pleura. So that comes with practice. The next, the middle part is showing what we extract from the lung, and you can clearly see there's a small tissue at the tip of that. Once you get this, you put the tip in the room temperature saline, and this allows thawing, and therefore you can get your tissue as shown in the final picture. It's a very interesting place that we are doing now because we are getting very good size specimens, and the pathologists are giving us very good feedback. This image was meant to compare the usual way in which we have been getting our biopsies using the forceps compared with using the cryoprobe. The upper image shows how a specimen comes out when you use the usual forceps. You can see it's a fairly small piece and it is crushed. But when you use a cryoprobe, you can approach the lesion in two ways. The first is where you go right into the tissue, and that gives you a tissue. Once you freeze, you get a tissue right around the cryoprobe. You may also go tangentially, especially for those lesions which are within the airway, and that gives you the lower kind of the specimen that we can see in the lower part of that picture. The advantages are that, number one, we get very good specimens which are not suffering from crash artifacts, and the cell layers remain intact. Indeed, it is comparable to a surgical lung biopsy if you are looking at the architecture of the tissue. Number two, because we are course, as we had vision well enough. In between, you can see the size is bigger. You're getting tissues as large as 1 centimeter across, and therefore the pathologist will have an easier time giving you all the information you need. And on the right side, we have the biopsy from a surgical biopsy technique. It is larger, of course, very much bigger, but then there are those issues we have already discussed about the cost, not just the financial cost, but also the cost in terms of having to keep patient in hospital for a longer period of time, test tubes, and so on. When one does the biopsy, this is what we see as we are extracting the tissue. It's completely frozen, and so we'll put it in some saline at room temperature so that it thaws, and then we can submit it for analysis in lab. Let us look at some of the indications for these cryobiopsies. Number one, and frequently, is biopsy of malignant endobronchial growths. The good thing with this is that it will give you a big chunk of tissue which you can use not only for histopathology, but also you can carry out tests like immunohistochemistry, which sometimes is a challenge when you just submit bronchoscopic forceps biopsy. The other things is that because you can do a tangential biopsy, if you have a lesion which is barely protruding out of the
biopsies are very, very easy to do with this procedure, and this we do for diffuse interstitial lung diseases of different types. And if one has proper airway guidance, you can even biopsy peripheral lung nodules. Cryobiopsy has also been used to assess lung rejection, lung transplant rejection, and you can do this early after you notice any changes in your patient's transplant. In patients who are getting lung conditions due to drug toxicity, cryobiopsies can help in terms of finding out what exactly is the kind of change or histopathologic change that these drugs are causing. Also, when you are monitoring patients on antifibrotic therapy, it is an easy process to get tissue so that you assess, is your patient fibrotic condition progressing the way you want? Has it slowed down? Has it worsened? Is there an acute worsening? All these things can be done using cryobiopsy. And this is possible because you are getting a very good size of tissue, which the pathologist can analyze fairly well. The key thing in a successful program is proper patient selection. This will mean that you have selected your patient so that you select those patients who you are likely to get a diagnosis. Number two, you select patients who are low risk for the different complications that we talk about below. Before sending a patient for cryobiopsy, it is important to have a clinical pathologic discussion and also discuss with the radiologist, because there are some diagnoses which we make using clinical and radiologic information, and therefore we may not need to send that patient for cryobiopsy. For instance, the usual interstitial pneumonia. In most cases, a sure diagnosis can be made just using a multidisciplinary TRIM approach. But in patients who have other acute or subacute lung diseases, which you are not sure of, and you can identify an area which is easy and amenable to biopsy, then this patient is a good candidate for transbronchial lung biopsy. Remember, when you are assessing your patient, you are considering, is this a patient whose diagnosis will be obtained by just clinical and radiology, or we need also to get a tissue biopsy? There are some contraindications when you're selecting your patients. Number one is bleeding diathesis. And any patient who has a problem with bleeding, because bleeding is one of the common side effects of this procedure, it is very important to make sure that this patient's bleeding tendency is within the normal range. Patients who are on anticoagulants of different types, for instance, heparin or the DOACs, these ones we need to manage them in a particular way so that we increase the probability that they will not bleed. And there are some studies which have been shown, and I'll discuss some of them as we continue. Patients who have thrombocytopenia and the usual cutoff is about 50,000. In this group of patients, there is a higher risk of bleeding, so we need to take care of them. Patients who have severe uncontrolled pulmonary hypertension have a higher risk of bleeding. This is a relative contraindication, so you need to assess your patient. In the past, some people are concerned about age limits, but the way it is now, if your patient is physiologically fit, age is not a limit for this kind of patients. Patients who have advanced airway diseases as well as parenchymal disease, such that they have a low functional lung volume, FVC of less than 50%, or a reduced DLCO of less than 35%. In these patients, be very careful, because if your patient complicates, they do not have a physiologic reserve and they are likely to get worse outcomes. Patients who have significant hypoxemia for the same reason. If the patient bleeds, then you are likely to end up requiring this patient to go to ICU because of worsening hypoxemia. There are other relative contraindications, for instance, obesity. In the past, they have been talking about patients with a BMI more than 30, and this also is because there is a concern about patients having hypoxemia once the procedure is underway. Sorry. Let us look at bleeding risk. And there's this gentleman who is called Ernst, who did about a study on 604 patients. And all these patients underwent the, sorry. Yeah, we have already talked about that. One reason these things are just going ahead, sorry about that. Let's get back to where we wanted to be. Yeah, this is where we want. So when this gentleman did his transbronchial lung biopsy study, he found patients who are on clopidogrel had a very high risk of bleeding. So checking what kind of medication the patient is on is very, very important. And specifically for clopidogrel, we need to stop it for at least 5 days before we do the procedure. For aspirin, in most cases, the aspirin recommendation is 3 days, although there are some studies which have done bronchoscopy and biopsies for patients on low dose aspirin, that is 75 milligrams, even without interrupting therapy, and there was not an excess bleeding risk for those patients. But most guidelines will talk about stopping aspirin for about 3 days. There are also guidelines looking at the other kind of anticoagulants and the duration they should also be avoided before doing the cryobiopsy. There's also a study which looked at platelet count, and they found that patients who had platelet count less than 60,000 had a higher risk of bleeding compared to patients who had normal platelet count. Other conditions to be wary about include liver dysfunction, because this may affect your INR, as well as uremia, because this affects the platelet function. So as we assess our patients, we have to look at all these things. What drugs are the patients on? Do they have a normal liver function? Do they have renal dysfunction? All these things are important so that you can select those patients who are at acceptable risk profile. Taking a bit long to shift to the other slide. Now, this one now looks at patients who have impaired pulmonary function. And the cutoff limit is, as we had discussed before, DLCO less than 35%. What we recognize is that in our circumstances, I think it's only one center in Nairobi or in Kenya which is able to do DLCO. And therefore, we may not have the luxury of doing our DLCOs in all the patients. And also, it's not a very cheap test to do in this country. Forced vital capacity is easier to get because one just does the usual spirometry so that you can risk profile your patient much better than if you didn't do these things. So as we prepare our patients in the pre-op period, we have to see the patients. Each patient must be assessed as an individual. We make sure they don't have active systemic coagulopathy. By doing your INR, you can do also a coagulation profile. For patients on warfarin, please stop the warfarin at least 5 days before and until their INR is less than 1.5. For those patients who must be on the warfarin, you can transition by using low molecular weight heparin 4 hours before the procedure. Clopidogrel we discontinue for between 5 to 7 days. So these are processes which must
patient going for the procedure. For patients on new anticoagulants, please follow the published guidelines and they are available. Patients with platelet count less than 50,000, those ones we are wary about. Now, with patients who have high pulmonary pressure above 50 millimeters of mercury, it is important to do a right heart catheterization if you have done the echocardiogram only. This will help you decide, is this patient fit for this procedure or not? Patients who have deteriorated lately over the last 30 days also tend to be high risk. So you want to choose a patient who has had stable disease. They tend to be high risk, especially in times of hypoxemia. And the basic workup that we must do for our patients is we do a full blood count, we check the coagulation, we do an echocardiogram to assess for pulmonary hypertension, and we also do a diagnostic spirometry. And once we have all this, we'll be able to select those patients who are low risk. We also must educate the patient about the risks. Patient and families need to know about the risks of bleeding, risk of admission to hospital, risk of chest tubes due to pneumothorax. All those things must be discussed with the patient and the family as the case may apply. Sorry, this thing is hanging. Give me just a second. Yeah, we have developed a protocol for the Avenue Hospital, and these are the things that we need in terms of equipment, and we usually insist that these are available at least 24 hours and working 24 hours before the procedure. Number one is the bronchoscope, the working bronchoscope. Number two, cryo machines. We talk about the issue of drugs like lignocaine. We have a filled carbon dioxide gas cylinder. We have cryoprobes, and currently we are using mainly 1.7 and 1.1. The issue of sterile trolley with kidney dishes. We ask for normal temperature saline as well as cold saline, about half a liter each. We ask and plan for fluoroscopy. We must have an endovascular balloon for bronchial occlusion, especially if a patient is bleeding. We generally use a size 8 or 8.5 endotracheal tube. We use a swivel cath adapter, and this allows us to continue ventilating the patient even as we are doing our procedure. An adapter. we ask for chest tube insertion set to be on standby. Here we're using picture catheters and ultrasound, so that in case our patients get pneumothorax, we are able to intervene quickly. In terms of personnel requirements, we usually will have a pulmonologist, an anesthetist, a dedicated assistant to handle the endobronchial balloon, fluoroscopy technician to deal with the fluoroscopy. We also have an assistant to handle the specimen, and also a runner nurse who will be useful in terms of sorting out any other things that may occur during the procedure. It is very important to have a crash cart on standby in case your patient complicates. These things will make sure they are ready at least 24 hours before the procedure. And we also have a checklist, and on the checklist we look at the HB, we look at the INR, we make sure the coagulation profile is okay, make sure that the echo has been done and we are happy with it. And all those things are checked very, very carefully so that we reduce the risk for our patients. The type of anesthesia we generally use is deep sedation, but sometimes we use general anesthesia. But we try to keep the patient breathing spontaneously. And we occasionally may use glycopyrrolate if the patient has got excessive secretion. I'm sure the doctor will discuss about the intra-procedure steps that are used. There are some complications which will occur with some patients. The key complications are bleeding, and there are many studies which have looked at bleeding, and the risk ranges from about 0% to even 20%, but the median is around 0.3%. So it is not a it can happen, and when it happens, sometimes it can be heavy, so one needs to be ready about it. We had a case where a patient read about this thing and found out that the bleeding risk can go up to 20%, and they were very scared about it. So please talk to your patient so that they understand, although those risks can happen, we are prepared to deal with it. The other risks that occur is pneumothorax, and that is why whenever we are doing these procedures, we are ready to fix a chest tube. The thing with this pneumothorax is that you will be able to diagnose it either immediately or a few hours down the line, and that is why we usually will ask for a chest X-ray about 2 to 4 hours after the procedure, so that we are sure we have not missed any of the late occurring pneumothoraces. So those are the common complications that may occur. Rarely one may be forced to abandon a procedure if, for instance, the patient becomes unstable or the patient is bleeding too much. You control the bleeding, and you may even postpone the procedure or abandon it altogether. Sorry, this thing is really hanging. But I think we have dealt with most of the things, and I will hand over to Professor Buika. Thank you very much.
Bado kuna time.
Come and see.
Yeah,
You met
did.
in Milan.
Imagine.
No, no, I'm not in Milan. Why?
I was in Milan. I was in Milan, but I don't remember. You met him. I only met Anguche. Remember, I took pictures of Anguche. This guy on the same pulmonary. I didn't even know. I knew there was a pulmonologist somewhere. But Anguche happened.
Anguche. Yeah, we did.
On a joint, Germany, see each other. Kenya, right? Yes.
Into the pleura and into the mediastinum, but we'll leave that out for today because we want to concentrate on the lung. So there's currently different sizes of biopsy, biopsy probes. So we have the reusable one, which were very short, so that you have the 1.1 and the 2.4. Commercially available is mostly the single use or the disposable one, at least in Europe, where you have the 1.1, the 1.7, and the 2.4. So the choice of the cryobiopsy that you're going to use is dependent on the bronchoscopy plan that you have. And I always get this question, so what do you mean about the bronchoscopy plan that you have? So I always try to keep it simple, and I say planning a cryobiopsy is like planning a night out with your friends on Saturday. So it's like, where are we going to go to? How are we going to get there? What are we going to drink? And what's going to happen afterwards? Like, who's driving home? So similarly to that, that's how you plan the bronchoscopy. So you have where we're going to go to, that's the CT scan that you need to prepare your way. How are we going to get there? That's the navigation or the bronchoscope choice that you have. And what are we going to drink? Or rather, what are we going to do is what kind of biopsy are we planning to take? Are we planning to do an ELD biopsy, so subpleural biopsy of the lung? Are we planning to do a tumor debulking? So that's where we're going to need a bigger probe. Or are we just planning to do a lymph node biopsy? So that's where we're going to use a smaller probe. So the last part being who's going to drive us home is like what complications can occur. And I always try to keep everything simple. And that's why I have this 3-step rule when it comes to transbronchial cryobiopsy. So it's like you have to have the appropriate cryoprobe, the appropriate preparation, and the correct implementation. Comparing that to my life, everyone knows me as a good pulmonologist, but the other thing that I'm known for is being a big sneaker collector, and that's a photo of my sneaker collection. So to compare the different situations where you have different cryobiopsies, I want to put it in the contents of my normal life where I have to decide what shoe do I take for what occasion. So, for example, if I'm thinking about doing a peripheral biopsy, I'm going to take the 1.1. The 1.1 is a smaller cryoprobe. It's more flexible. Owing to its smaller size, I can use it with relatively slim bronchoscopes, meaning I can get further down. That's like the Adidas Superstar. It's small, it's comfortable. You can use it at any time. The disadvantage to the shoe and to the 1.1 cryoprobes is that it's very small. So after a while, the shoe gets annoying, but similarly to the 1.1, you won't get as big of a tissue feedback. You don't get a big tissue sample as compared to the 1.7. But it's still, in comparison to the needle aspiration and to the forceps biopsy, even better. And then what about the regular day shoes? So that would be the Air Force One. And that's, in this case, we're talking about interstitial lung disease. That's where the cryobiopsy kind of made its name. Although you can use the 2.4 cryo probe, which is the biggest one, the 1.7 with the single-use one and the 1.9 in the reusable one have been shown to have the better samples. They're more flexible, meaning you can get further down, and the size comparison of both samples that you get with both sizes were 2.4 and 1.9 or 2.4 and 1.7 are comparable, meaning it's better to just go for the 1.7. The next situation is cryodebulking. So cryodebulking means you're going to be working for a long time. You need something that's going to help you get to the point that you want to go to quick and still not be as stressful as the other stuff. And that's the Ultra Boost. So in this case, you do the 2.4 cryoprobe because it offers the usability that you can have bigger chunks of tumor being taken out and in a quicker fashion. So you don't have to really have the tedious going back 7, 8, 9 times to debulk the tumor. Although you could use a 1.7, it's comparable. The 2.4 offers way more tissue debulking, especially in the central tumors. When you're going further down in the periphery, then I would prefer the 1.7. So moving on, the mediastinal cryobiopsy, which I kind of hinted on, that's the new fad that everyone is doing. The 1.7 could be used in the mediastinal cryobiopsy. It's harder to put in because the working channel of the ebuscope is usually 2.0. And most of the people who in my realm do it with a needle, meaning you have a needle that's mostly 22 gauge, so 0.7 millimeters in diameter. So putting in a 1.7 cryoprobe is kind of a challenge. The 1.1 is pretty easy. And when we're talking about lymph nodes, you don't really need that much of a big sample. Yeah, a small sample is okay. So the 1.1 is fine. And coming to the second to last part, it's the interpleural biopsy. The interpleural cryobiopsy, it's becoming one of the complementary tools when you're talking about detection of pleural malignancy. Although the diagnostic yield is not higher compared to the thoracoscopic forceps biopsy, due to the fact that you have well-preserved material, you can be able to do more testing when it comes to malignancy. And when we're talking about more material, especially in pleural mesothelioma, where it's like a patchy disease, you have sporadic different spots where the disease is visible, you need the 2.4 millimeter cryoprobe because the 1.7 is just not enough. The second to last one, sorry, I missed one, is the apical lesions. I think that speaks for itself. You have to have the 1.1 cryoprobe because it's more flexible. When you're doing a biopsy, especially in the right upper lobe in the RB1, you can't use the 1.7 easily. With the 1.9, you could do a bit of an angulation where you bend the cryoprobe beforehand, and when you go into the bronchoscope with it, it's already angulated so you can move it up forward. With the newer cryoprobes, it's a little bit harder because when you bend it, you could run the risk of breaking it. So the easiest recommendation I give is just go for the 1.1 because you're more flexible. There's nothing more annoying than finding your way up into the right upper lobe and not having a cryoprobe that fits into it. And the last one is, of course, the tracheal cryotherapy, which we've already mentioned. That's in situations where you have stenosis of the trachea and you want to take out or you want to devitalize the mucosa along the way. You can do that with a 2.4, but with the 1.1, you have better movement. So it's easier for you to pick a spot that you want to devitalize at that time. And moving on to the second part of the rule, that's the appropriate preparation. I'm not going to talk too much about that because we already mentioned everything that you have to do. But to summarize, it's basically you need an echocardiography to rule out pulmonary hypertension because of bleeding. A very, 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 very important thing I have to say is the CT scan. A native or high-resolution CT scan is sufficient when you're talking about the pulmonary fibrosis. But when you're talking about every other pathology regarding the lung, you do need contrast media. In Berlin, about 10 years ago, there was a complication that happened where a CT scan was done and there was suspicion of lung cancer with a nodule in the right lower lobe. But it turned out that that nodule was actually a vessel malformation. So because contrast media wasn't used, they ended up doing a biopsy on one of the pulmonary artery, which ended up to a massive hemorrhage, and the patient unfortunately died. So thing I tell everyone is when it's possible, do a contrast media CT scan, especially if you're talking about or if you're handling diseases such as lung cancer or mediastinal malignancy. So now, the biggest part of my talk is the implementation, because I think that's what we're all interested in. What do I do when I get started? What's the most important thing? What do I have to look out for? Taking a biopsy, the cryoprobe is it's like a bullseye effect or a bullseye concept. The more central you are, the higher the chance of hemorrhage. That's why it's marked out with red. When you go out in the periphery, you have a high chance of pneumothorax. So you kind of want to have a sweet spot where you're not too far out in the periphery and having and causing a pneumothorax, but you're not in the center of the lung where the vessels are bigger and you end up having a bigger lung bleeding. So we're going to go step by step about the things that you're going to need. The first thing you're going to need is an airway management. I think proper airway management is a necessity when it comes to transbronchial cryobiopsy. There's been various studies and various centers that have shown there's a feasibility of doing cryobiopsies in non-intubated patients, but the general recommendation is having a secure airway is the best situation that you can have when it comes to complications. The rigid bronchoscope offers more flexibility because you have a bigger bezel, so you can have a mechanical tamponade if you need to, taking the forceps and the gauze and pushing down on the area that's bleeding, or you can have a bronchus blocker or Fogarty balloon going parallel to the flexible bronchoscope that's in the rigid scope in order to block out the region. But personally, I think the flexible bronchoscopy is just as good. If you're using an ET tube or sometimes even a laryngeal mask, you're still able to perform the exact same cryobiopsy with the exact same security. The importance of the airway management is just being able to go out and go back in case anything. So the balloon placement is the second part. Where we mentioned it a little bit, you place a Fogarty balloon prophylactically to aid in taking the biopsy, so that as soon as you take out the cryobiopsy, you inflate the balloon, which ends up placing a mechanical pressure on the biopsy spot, which helps in bleeding management. Disregarding the cost factor about the balloon, one consideration that a lot of people don't take into mind is that it still requires training. The balloons are very easy to use and easy to implement. The problem is if you have a nurse using it for the first time, you'll have improper displacement or improper placement, I should say, or improper inflation. So you're inflating the balloon too quick. It's not been rare that I've taken out the cryobiopsy and taken a piece of the balloon as well because it was inflated too quickly. So that's something you need to take into consideration when you're deciding to start with the cryobiopsy for the first time. Take your nurses to the side or take the doctor that's helping you to the side and practice using the balloon before you start using it on the patient. Fluoroscopy is a very, very important thing. I think in this day and age, fluoroscopy has become standard when it comes to transbronchial cryobiopsy. When it was initially launched, the transbronchial cryobiopsy was done with a tactile feedback. So you'd go. You got a tactile resistance. You knew what the pleural region, so you pull back 1 centimeter and take a biopsy. This is in suspicion of interstitial lung diseases where the fibrosis or the lung changes are always near to the pleura, so you're taking subpleural biopsy, and that's why the tactile feedback was the method that was used. The problem is if you're using a 2.4 millimeter cryoprobe, I'll demonstrate with my hand. If we say that my thumb is the pleura, I could end up hitting a sub-segment carina and thinking that I'm in the pleura. So that's why you need the fluoroscopy to make sure that you are at the pleural region, and then you can pull back under fluoroscopic guidance to take the biopsy. With the 1.1 cryoprobe that's new, I cannot stress that enough that you have to use the fluoroscopy, because seeing that it's so small, even though it's blunt, you can still cause a mechanical pneumothorax with it. I've seen that happen quite a while. So I know there's still centers that do it with a tactile feedback. Even in Germany, there's a big center that does it that way, which is still fine. But when it comes to the smaller probes, the 1.1, I wouldn't recommend it. So here's a demonstration of us doing a cryobiopsy on a patient who had suspicion of an NSIP. So he's intubated with the rigid scope. My colleague is on the side to the left of me with the balloon ready. The nurse is on the right, ready to take the sample. So I'm going to play the video. Another thing that you can consider whilst doing the cryobiopsies is the imaging modalities that are available. With the current bronchoscopy systems that are there, whether it be Olympus, Fujifilm, and Pentax, there's always an image modality in place to highlight the vessel network. The narrowband imaging, I think, is the most popular one from Olympus, but you do have the BLI and the iScan on the BLI on Fuji and the iScan on Pentax. Implementing this modalities helps you know where you can perform the biopsy, especially in exophytic tumors where bleeding is the highest complication that you're afraid of. So you can always preempt the bleeding by applying an NBI or BLI or an iScan on the section that you want to take the biopsy, and then decide whether or not it's a viable situation, it's a viable position. And somewhat newer trick that interventional pulmonologists use here in Germany is using the radio EBUS when doing the transbronchial cryobiopsy of interstitial lung disease, where they look for vessels in place at the zone that they want to take the biopsy at. And when the radial EBUS is negative, they would then do the cryobiopsy. And of course, if you want to go for the more expensive version, you can do the virtual bronchoscopy, because the virtual bronchoscopy not only tells you where you can go or how you can take the biopsy, but rather also highlights the vessels that are in the region. So here's an example of a virtual bronchoscopy from the company Fuji. So the yellow part in the screen is the tumor that I was going to biopsy at the day. You can see in little highlights of the vessels in blue. So you have a map here of the airways while you're looking at the biopsy zone, and then you can inject the blood vessels that are near to the zone so that you can say this is a viable zone or this is not a viable zone. So another thing that we also have to consider is the hemostatic agents and the hemostasis. You always have to have a plan B. So when you're starting with the cryobiopsy, I always recommend you to pick out one agent that you are accustomed to, whether it be tranexamic acid, adrenaline, or even cold saline, but always have it ready so that when you start doing the biopsy, in case a bleeding occurs, you're ready to stop it when it starts. There's recommendations from a couple of centers where they say you should apply prophylactically the hemostatic agents, so tranexamic acid or adrenaline. There's not many studies confirming this, but let me say it's eminence-based, not evidence-based, but that's a recommendation that you could choose to do. So apply like 1 milligram diluted in 100 milliliters of saline solution of adrenaline, and apply it in a subsegment before doing the cryobiopsy. But I think the most important thing is having a plan in case it starts to bleed. So that's why I always say it's not only the hemostatic agents that you need to have, you also need to think about what happens when it's too much for the hemostatic agents. And that's where APC and laser and also the bronchos blocker or the Fogarty balloon that we talked about come into play. So this is an example of APC. So a patient who was doing a debulking on, she had a big tumor in the right upper lobe. So as you can see, I'm trying to do a coagulation as much as I can on the tumor before I start doing the cryobiopsy, because with the tumors, you can not see in the distal end, so you don't know what blood vessels are there. So doing the APC beforehand helps to reduce the bleeding once you start, but also you can do it after the biopsy. So when it comes to freezing time, depending on what paper you read, you're going to have a different recommendation on how long you should freeze. There are some general recommendations when it comes to different probes. For example, if you're doing a mediastinal cryobiopsy, they say with a 1.1 probe, you should do 4 to 6 seconds. When you're doing a biopsy of the lung, when it comes to interstitial lung disease for the subpleural region, you should use a 1.7 for 6 to 8 seconds. What I recommend everyone, despite your experience, is start with 3 to 4 seconds. Especially if you don't have a Fogarty balloon in place. Start with 3 to 4 seconds, take the sample out, judge the sample size. If it's good enough, look at the bleeding that happens after, and then you can decide, okay, I have a smaller sample than I actually wanted. The bleeding is moderate or not existent, so I'll step up to 5 to 6 seconds, and then in the end take the 8-second sample. I know that slows down the rate of the biopsies, but it helps test the waters before you take the bigger biopsies, which could end up being the one that bleeds. So here's an example. In this case, I froze for about 9 seconds with the 2.4 probe. Some might say it was a lot, but there's a reason why I was able to do that. It was a patient with tumor in the right upper lobe. I had the colleague doing the tandem debulking, which I'll show later. So I had the security of knowing, even if the bleeding starts, we're still able to stop it, in that I can deal with my biopsy on the right side whilst my colleague deals with the hemostasis. And that's the topic, or that's the theme of the last part, which is teamwork. One of the crucial aspects in safety and avoiding complications is having a team that's well trained, repeating the training, and having an open communication. You shouldn't shy away from getting assistance, whether it be your first case or whether it be your 10,000 case. It's just important to always call for help immediately as a complication turns out. I remember when Naveed was doing his first cryo biopsy, I couldn't be there, so we ended up doing it on Zoom. So you don't have to physically be there to help, but you just have to be present. And here, this is the video I was talking about, the tandem debulking. So it's a patient who has a tumor on the right upper lobe. So I'm in charge now of taking the biopsy, while my colleague to my right in the video is in charge of the hemostasis. So it went this way. And as you can see, it ended up working well because we were both able to concentrate on our roles and make an efficient cryo biopsy. And the last thing I want to talk about is something that I hold very, very dear, and that's the team timeout. I can't overstate this enough, that that's one of the most important parts of practicing bronchoscopy. A good communication during the bronchoscopy and maximum concentration is the key to having a safe and precise procedure. A team timeout should always take place beforehand, where everyone understands what we're going to do, and it should be a very loud and clear communication. We're going to do a biopsy in the right upper lobe. This and this could happen. This is your role. This is your role. This is how long we're going to take, so that everyone is on the same page as soon as the bronchoscopy starts. There's different studies to it. I'll show you a quick video of how we used to do it in my old clinic. So this was a patient who I was planning to do a peripheral biopsy on. These are the two nurses that were there. So we always discuss the CT scans before, where I look at the region that we're going to take, and I was showing them on the virtual bronchoscopy where we're going to do it. And in the end, it was a good bronchoscopy because everyone knew what they were going to do. So you can have different methods. There's the huddle mentality, like a football team. There's a team meditation. I believe in openly communicating with everyone beforehand. What we always used to do is do a lot of music, which I still hold very dear to me, because it ends up reducing the stress in the bronchoscopy room. Well, it depends on the music taste you have. Sometimes you work a little bit harder when there's music playing in the background. Sometimes you work a little bit slower. And if someone asks me, what would you recommend? These are the 6 albums that I would tell you. If you want to start with bronchoscopy, download them, play them in the bronchoscopy. It'll help you concentrate better. And if you don't believe me, once you see this study and hear this song, of course, you're in the mood to do the bronchoscopy. And if you don't have a list, here's mine. You can take a photo of it. This is a Spotify playlist that I always curate with different songs. So to finish up my talk, I'm just going to give you a small case about cryo debulking, which kind of highlights everything we talked about. It's a patient with a highly vascularized tumor that you can see. I'll try to highlight over here. And we decided to do a rigid bronchoscopy with a cryo debulking with a 1.7 millimeter probe, because it was more flexible in the end. So that's us taking smaller pieces out. And going back in to check the bleeding. But the reason why I'm showing you that is to show you why we do it. This is a patient who came in on the 28th of June last year with massive respiratory insufficiency. We did the debulking on the next day, and you can look at the X-ray right after. This is the tumor-filled lung beforehand, and this is the lung about a day and a half later. And I want to thank Naveed for giving me the chance to talk to you guys. And we don't always remember to thank your family, but I always try to remember to thank my family for everything that I do. So this is my current family, my IP family with Miguel and Javier, who's been there for a lot of projects that we're doing. And I want to thank them for their assistance that they've always given me. We're always open when you have questions. If you end up seeing this logo somewhere, you always know that something good is happening. So in a couple of weeks, there's going to be a project launching. So if you're interested in learning more about cryobiopsy, more about intervention pulmonology, look out for this logo, look out for a project. And here are my details in case you want to talk to me about anything. Thank you. So I just got the message that Juma is on a call. Do you guys have any questions? I'll look into the chat to see if there's anything. case. Everyone is waiting. I'm waiting as well. So I'm kind of excited.
Thank you, Sandy.
Thank
So
you.
we're going to switch to a different feed and take you through the case now.
Okay.
Okay, thank you.
Thank you.
So our patient is on the table. She's already being sedated. The timeout has already been done. And we're going to put in an ET tube size 8, so which is a large ET tube. We want the space, we want a size 8 tube because it gives us enough space for the bronchoscope, the probes and the balloon to fit comfortably. Otherwise it's all going to get clogged in there. The probe we're using here is a 1.7 probe. It allows us to get to the lower lobe quite comfortably with some little flexibility. The 1.1, we don't think it's going to give us enough sample size for this particular patient. And we will freeze anywhere between 3 to 6 seconds. We start slow and progress upwards as we check for bleeding. We will be using a balloon blocker or a Fogarty balloon. We'll show you how to place the balloon as we do the procedure. The procedure is done under fluoroscopy. So we've got our C-arm and we're going to set it up as I move inside. So if there's no further questions or if we're all good to move inside, then I think we can start in theater. Yeah. Good. We're ready? Just check if we can come inside. Yeah, so our anesthetist, Dr. Gitao, is in the back there. She's responsible for the airway. She's going to keep the patient sedated. We'll discuss the anesthetic concerns with her. My colleague, Dr. Waweru, is there. And we've got some other visiting specialists there, Dr. Andrew Awar and Dr. Jackie Kagema. Our theater team is already set. Our fluoroscopy technician is already set. Yeah. So I'm going to move inside now. You can follow me. Huh?
I'm telling Micah to help me with the mouth guard. You remember I've been borrowing you a mouth guard?
Yeah.
Very long time.
In fact, talk to him.
I'm talking to
He's
him.
the guy.
He's just laughing.
Yeah, it's hard to get it. Yeah. So again, here it's more like adapting what you have, and which is what took us the time. Yeah. Even 8.5 is not available. So we're on. Okay, so we're on. Good. All right. So this is how we do our cryobiopsy. We have the airway secured, and our anesthetist, Dr. Sheila, you can give everybody a wave. All right. Dr. Waweru is there. That's Micah, of our fluoroscopy expert. Dr. Kagima, Dr. Andrew. Our biomed is on standby in case we have any issues, and that's Max. So welcome. This is our suite. Our fluoroscopy machine is there. We're going to set it up immediately now. We do all cryos, at least in this hospital, with fluoroscopy. We try as much as possible not to do it without. This is the cryo machine. It's the Airbe Cryo 2. It is coded to the probe, so when you put the probe in it, the serial number comes on the screen. and you can program specific settings if you need to. So it's fairly simple. It's controlled by a foot switch next to me there, and the fluoroscopy is controlled by the foot switches that will be next to me as well. The probe is single use, so this is ready for use now. And usually when we do it, the first thing we do is we test our equipment. So I'll ask Dr. Waweru here to do we do a little ice test. So I'm going to put the probe in some saline, and I'll ask you to step on the pedal. So put it in the saline, yeah. Okay, so just freeze like 5 seconds.
1003, 1004, 1005, 1000.
Yeah, you can take it out. There you can see the little ice ball at the end of it. So that tells us, one, the probe is working and we have enough gas in here. And the second is, it's going to tell us roughly, if we froze for 5 seconds, what sample size are we going to get. And this is a fairly good chunk. So we do this before every procedure. We make sure everything's working like that. Then on this side, now this is the rest of the equipment we have. So we've got a balloon here, which you'll see us placing during the procedure. Yeah, so this is a Fogarty balloon. This one has a stylet, so we like this because it lets us get it into the right place. We've tested the balloon again, so I'm not going to retest it, but we'll show you how to place it during the procedure. Then we've got our sample dishes and everything that we need. All the kidney dishes are under here. There's saline, and that's for the sample. Yeah. Then we've got emergency tranexamic acid here. We've got syringes of adrenaline here. There's iced saline ready, and we've got our lignocaine and regular saline to do the bowel. So, any questions from you guys? Andrew, Jackie, anything?
Have you shown them how to test
Yeah, we had done this. I don't want to pop it because I don't have another one. But last thing I'll say is anesthetic considerations. Dr. Gitau, she's done a couple of cryos now with us. So, what's the anesthetic angle on this?
because it's a shared airway, so first it has to be the appropriate patient. Make sure that the patient, in terms of intubation and airway management, that it's okay. So she's not particularly long there. So in terms of the airway management, completely straightforward for intubation. The other thing is, because we're sharing the airway, once we start, ideally the patient should be spontaneously breathing, so that because we will be interrupting the flow from the successive machine, at least we maintain the patient oxygenated. Because she's breathing spontaneously, they're not worried that it's about the compensation. So the other consideration is the cryo is high energy, so there's a risk of other tissues being damaged. So you look at your airway, there's a procedure is going
Regular,
on.
like us.
You look out for it bleeding.
We have the same kind of setup actually.
Yeah. From the anesthesia side, use IV. They will have it distributed locally. They have the adrenaline. I have my resuscitation drugs ready. And yeah, so we just keep an eye out, make sure we don't have any complications. This being our third, I think so far so good. Right?
Okay.
I'm gonna step over there.
Are you ready? Let's move up a little bit towards me. Yeah, let's pull her up. Do you have gloves, Michael? You have gloves 8. Is that a bit tight? Give me 8. This one's a little bit tight for me.
We're just going to move her a little bit closer.
Lamp on. Give some gauzes.
On the patient. Can you just come here?
Okay. Yeah, we'll just do a quick wash first. Thanks. Yeah, it's okay. All right. Let's work through this nicely. Okay, your side, she's okay? Anesthetic side.
It's coughing now.
tape it nicely. Okay, sure. I can start. Suction and fluoroscopy. I need the CM. Let's get the CM on before we start, please. That way it's just it's straight. Yeah, Sheila, if you're set, we can bring the CM in now. Drip stand. Yeah.
That's fine.
Let's get this drip stand out of the way. Okay. Okay, so I like to get the cables out of the way because everything just looks funny on the with the fluoro. Yeah, it starts to look off. So you just use something to sort of direct. Or to There's a big cable, yeah. Okay, good. Give me a test image.
There's a fellow there.
Someone has he needs to be outside. Yeah, good. Now, no, make it a bit straighter. Turn it anti-clockwise, like 10 degrees. A little more clockwise now. Yeah, that's okay. All right. Now we need it. It's taking too much of the bed. I need more of the chest. So let's get it in a bit.
Yes. No, this is that. You will get another one. Yeah. Make another size 8. Start a glove. Yeah. Yeah, but don't trust this.
That's not so bad.
Yeah.
Good.
Try it again.
There, you can see the diaphragm, or you can see the dome rather.
Yeah.
Yeah, you can see the angle.
That's a good position.
You can see the angle, and you can see the marker. So, oh, that's my hand on this. Yeah, lock it here. Okay, I think we're good. Anything else we need?
Two.
Just
Thank
2
you.
cc, yeah.
Thank
I
you.
only have one.
I'm just
You gotta carry one spare and first one, but just okay, let's get this. I think we'll just work with the screen maybe a little sideways. Okay, good. Should I have look? I can go in?
Take a better picture. Very blurry, I don't know why. Yeah, good.
I'm just gonna inspect the left side.
Yeah, and if you want to wash, we can wash.
There's nothing really here. We'll just focus on the lower lobe.
Yeah.
That's where the disease mostly is. Superior segment ABC.
Yeah.
Basal segment left lower lobe. Nothing in columnar, nothing in columnar, nothing in columnar.
Quite good.
Yeah, quite clean actually. The band I'll do from the
At the right
yeah,
side,
the right
yeah.
side. The disease will be a little more dense there.
The biopsy.
And I'll put a little more saline
Okay.
on that side. I don't know if that has too much.
True.
You getting enough sample?
Yeah, on this side you're good.
Good. That side? Right, doctor? It's coming, you see the two segments?
Yeah.
It's coming,
From
you're
the
not
side.
seeing all three immediately.
The apical is inside the anterior.
Yeah.
It's actually there.
Yeah.
That's it, that's the posterior segment, but you can see it looks all normal.
Yeah.
It's a bit dirty, it's a little low. Huh? Yeah, yeah. In fact, this is where we wanted to focus a little more on.
On the right.
Yes, and the basal segments,
Yeah.
yeah. There was a lot more going on here than left. You're getting sample?
Yeah. Little though.
We need some more. Because that's low, low. Do you get there now? Yeah. Tell me when it's done. And this is where we're going to take the cryo. So
Yeah.
anterior lateral, posterior basal segments. Yeah, any one of these two I think is okay. This is where it looked a little more dense.
Posterior, go on.
Yeah, so I think even the balloon placement, if it gets into
Can go
this
any
bronchus,
of them. Wash that area.
Any of the two.
and you saw how finicky placing that was last time.
This is a good area.
Yeah.
Shouldn't be a problem.
And it's just direction there, so
are good.
So well done.
You want to connect directly?
Yeah, let's connect this one. Come on, come on. Okay, so I'm gonna come up so that the balloon can go in now. Then I'm gonna chase.
Label this. Yeah, bronchial wash. The
Let's put that in. You're doing well. Thanks, man. Okay, so now we're just gonna put the balloon in. So we use the side port here. So
behaving very well.
yeah, I know. Normally gives us a bit of a headache getting through the connectors. So today is a good day. Alright, so I'm gonna just put it like down the ET tube, and then now what we do is we follow with the bronchoscope. Then we make sure that it's getting into the sub-segment that we want to. It tends to be a bit of a hit or miss because it's not a steerable, or it's not a balloon that you can sort of direct very easily. So it can be a bit of a pain at times.
Just fatigue until you get.
So you see,
The blocker is expensive and
it's very
difficult
expensive.
to find.
So you see, you can tell balloon now is going.
Okay.
And it's heading in the right side. So I'm going to follow it as we push it down now. We need it in the right follow. So you, yeah. So
I think you could just put right there.
get in a bit deeper.
yeah,
You know this balloon gets in quite deep, huh? Nothing with it is here. That's
yeah. I come with the yeah. Guide.
yeah, guide wire can come out. We can test it in there. It's also because I'm a little better at placing them now.
The right side is not across.
Yeah, it doesn't tend to be just push it in. Yeah, it can inflate it.
On the left.
Yeah, so we inflate the direct visual so that we can see the balloon.
So I'm going to inflate.
Yeah.
Yeah,
Yeah, it is. But just deflate it, pull it out a bit. Yeah. So you see, you can do
It
this.
does mark a
yeah,
Okay,
there, yeah,
that's the balloon. Yeah.
yeah.
Yeah. So you see, we're gonna put so
So we can start here.
we'll tape this here now because we like it staying in place, and it does move. You saw it last time.
You wanna put it a bit deeper than deeper that it moves a little bit.
Yeah, and then we can do with it as we do it.
Yeah,
So-
you're good.
You can see where I am on the fluoroscopy.
Yeah, that's good.
You see
The
where
probe-
actually you can see where the
Oh, that's a balloon.
that's the scope. You can't see the balloon unless you put contrast.
Yeah.
You can use contrast to inflate the balloon, but it tends to be thick and quite viscous. So I don't like using it because you can pop the balloon with it as well. But yeah, if you want to know the balloon placement accurately, you need to fill it with contrast instead. Okay, good. Cryoprobe.
Cryoprobe.
Yeah, so again, it tends to be a little bit of a squeeze in here, but we work it out.
You're using a 1.7.
1.7 probe going in, yeah. There you go. As you see, there. So you can see it's posterior. That's why it looks like this, because I'm not in the diaphragm, as you might imagine, but that's why we use two techniques. One is we feel where it is, so that's the end of the probe right there, and then I'm going to pull it back about 2 centimeters. Because it's gone into the posterior segment, this is a 2D image. So like how you have it in PA view on an X-ray.
Rotate your floor if you want to see that.
But this is the actual end of the segment. So we're going to come back about 2 centimeters. So the sweet spot is about between 2 and 4 centimeters. And that way, that's how we mark it. Not a liver as it looks. It's actually posterior. Alright, okay, we're ready. The probe is fine with me now. Ready for sample? Okay, we'll start with 4 seconds. 1, 2, 3, and 4. Container. That one. There's a And our balloon has already been inflated.
About 6 seconds?
4. That was 4.
That was 4. So we can.
So we check first. Yes, that's a tissue sample. Put the balloon in there. So cryoprobe can come out. Yeah. You got the probe? Okay, so now step 2, we're going to check if there's any bleeding. So we hope our balloon stayed in place, but so far it's okay.
Clean.
Yeah, so far.
That place is not bleeding.
Okay. And if you look at that, that's the balloon there. It's inflated, the bronchus is blocked off.
Yeah.
So now you can deflate it. And we check and you see
Just a little.
just a little bleeding, so usually. Okay, good. Good. Alright, so cryoprobe. So we go in again. Can break. Be careful on it.
Yeah.
Just for the console, I told you.
Yeah. Yeah.
Just for the console for
You can see where it is already. That's the end.
Yeah.
I'm gonna come back out about 2 centimeters.
Yeah.
Okay, so I'm gonna freeze. Can do. Same, we can do 4.
1, 2, 3, 4. Give it time. Give it time. Give it time.
So it'll almost like 4.5 seconds.
Oh, it's out. Okay.
We can watch the end of the probe.
Yeah.
that's when you can maybe try 6.
Yeah, we can do about 6. Yeah, that's okay.
Yeah.
Good. So the technique for taking the sample is a sharp jerk.
Yeah.
So and this is where, when you're taking the sample, so I'm going to demonstrate on air, but assuming it's in, you have to really just yank it in one sharp motion. If you yank it, and what I do is I always grip the probe itself, sort of in these fingers, so that when I pull it out, the probe is not stuck and it's not sliding over the probe. It makes it easier to come out sharply. If, for example, you pull and you find it's stuck, so then you release the pedal, wait for it to thaw. Once it's thawed, like maybe 10-15 seconds, come out and try again. That's the general idea. Alright. Because you can tear the bronchus with this, it's quite powerful. And if you've ever used this in the pleura, which is that one, it does tend to be quite strong, this thing. So we're going back in now. There you go. Nice placement. Very nice. I'm gonna deflate it a bit. No, nothing there. Okay, good. You wanna take another sample? Cryoprobe. So this, you can see there isn't much bleeding, and and we're happy with our balloon, so we're gonna go back for a third sample. So as soon as the probe is out, even if my vision is not so good, I just use the fluoroscopy to see where I'm going now. So you can see on the fluoro, we're again posterior. So I'm going to come back out maybe 2 centimeters. You can even recheck it here, see? But that's okay. Then we can 2, 3, 4, and 5. Yeah, the recommendation is 3 to 6 from usually 2 segments. So we've done, we'll see. Yeah, we can take another one from a different segment. Yeah, but probe can come out now. Let's check in for bleeding. Okay. Okay, so you can see we're happy with our placement. It's in place thanks to Dr. excellent work here. Yeah. Good. Yeah. And there's a bit of bleeding, so what we do is I'm going to put some saline in there.
Some adrenaline.
Yeah, and inflate it in there. Yeah. Now we suction it out. So what we do is we usually just tamponade it back with the balloon. You see this. We took a bigger sample, so it's expected. Blocker is just stop it now. So we wait like maybe 30 seconds or so. Wait for it to cool off. Then we recheck. So I'm actually against the balloon wall. You see where the tip is sitting. Actually, yeah. You want to ventilate her for a bit? I'm going to come up. We'll wait a couple of seconds, let her ventilate. We get the tidal volume back. You see that our flora image is still good. You can see there's no air leaking out.
Yeah. True.
You want to swap? Want to take a couple of samples? Okay, so I'm going to swap over here now. I'm going to man the balloon.
Yeah. Oh, you know. I can cover that one. Oh, you remove it because you are going to move it anyway. Oh, I have ballooned it down there.
That's okay, I've opened it now. It can stay in place because you're going to take another sample.
Yeah.
What I think we
Do you
can
take to the same or you move to another?
Let's try a different,
the lower one.
lower segment.
Yeah, that's okay.
Yeah, so you can see our pieces.
Yeah.
They're not bad. Yeah, so we're going to take a couple more.
When they come, I need some drugs.
I'm thinking of removing the tape so that we close this place.
We can always put it back in.
Yeah.
I'll get this because Kenya cook pulled out of Kenya. They withdrew from the Kenyan market for corruption and all this.
The sanitized. They are giving us the sanitized.
Because we don't want the patient coughing during the biopsy. Make it fine. Also, it makes it hard because the throat and tongue get loose when they're coughing. So we like when you come. That way you have the headspace to see what is happening properly.
you're still in the same nice place.
So you can, what I'm going to do is I can pull the balloon out a little bit.
And push it
Let's inflate it here. That way you can see you can take from any one of those.
to the others.
Yeah, yeah. So let me pull the guide wire out.
I try here.
Yeah, I think it's
that's
but let's
okay.
see where the balloon is blocking. Because what helps a lot,
Yeah, you're good.
see,
You're
the
good.
balloon is good. So what I'm going to do is I'm going to just take the balloon in place.
Yeah.
And then you can take your specimen from any one of the segments you want. Okay, when you're ready.
Yeah.
I'm ready when you are. That's
With
a
a
small
clot,
clot here.
Yeah, which is fine.
You can do a 5-second freeze. Should be okay.
I want to get here. And try here.
Yeah.
This one.
Yeah, even the up one.
Cryoprop.
So the different blockers, so we have this is a bit deeper. The other one we have here is an easy blocker. The easy blocker is a double, it's used for single lung isolation. It sits at the corona. Then you can block the right main bronchus or the left main bronchus at choice. That is good, I find, for if you're doing thoracoscopy and you need some apnea. Oh. Okay. Check flora. Yeah. Yeah, pull back. Yeah, maybe 2.5 centimeters. Yeah, that's not bad. Okay, I'm ready when you are. Yeah.
1,000, 2, 1,003, 1,004, 1,005.
Excellent. We went to, I think it was, but it was a different sub-segment. Okay. Good.
Thank you.
Let's see, we've got some good pieces now. I think these are 4. These are quite good.
I take one.
Yeah. Let me deflate this.
Balloon came out.
Yeah, I think it's dislodged. Okay, fine. Okay. You see, we've got a little bit of bleeding now. But when you take bigger samples, you get a bit of bleeding. The good thing is with the blocker in place, usually we're fairly when no.
This is not major bleeding.
That's adrenaline. I'm just giving it
In
some.
fact, what I'll do is I'll block the balloon for in there for a bit, so you get some. Yeah.
Just press the balloon. Yeah.
I'm gonna pull it out a bit.
Good. I think you can get a biopsy.
Yeah, yeah. I'll keep the balloon here. Yeah, it helps. We find I've used the one without and with. I like this one, so I'm happy with it. But you see the blocker is right in that bronchus. So if we're tired, we can block it off now. Yeah. And there we go. So this tends to be a bit of an insurance policy. This blocker helps us because it's an insurance policy. But you can do it with, okay, I shouldn't say that on camera. Catastrophic. Yeah, you can get it from there. No, go where the balloon is. Any of those, just put it, yeah, in any of these, yeah. You can even get it up. Yes, let's check with the floor. So keep going until you feel resistance. Okay, then come back about 2 centimeters. Yeah, we're taking from a different segment. That's good. When you're ready, I'll put the. That's more like the anterior basal where we can take in. So this one. No, it's okay. It's not bad. You took a 4 second. No, I think we're good now. Yeah. We've got about 5 pieces now. So. Yep. So you can look now, see with the balloon. It's blocked off whatever was going to bleed. Now we're going to check. You want to take a sample? Yeah, sure. Yeah, sure. So the placement's okay. Come.
Oh, there was a pack here.
Just doing many. Once you do many, then
Yeah, no, we got.
which pedal is for white pedal?
This is for fluoro, this one, and this for, and when you press to get the sample, don't release until the sample is out. Don't release the pedal because it will thaw and fall in.
No, it happens. Let me just practice. Let me just practice. So this is the cryo. Yeah, that's the cryo pedal. Right? And I cannot just practice it. Yeah. You take the probe. The probe. And just count. Yeah. Until I'm all complete on the list. So the motion is going to be very nice. Just yank it like a very quick jerk. And once you see him coming out, you press the balloon. And just make sure it doesn't
Blur. Okay, yeah. It's okay. Once you put the probe in, I'll walk you through it, yeah.
Fluoro is here. This is continuous.
And stat image.
Continuous is the blue.
Yeah, so I like the continuous, yeah. Also, once the probe is out of the thing, with the continuous imaging, you don't really need to look here. Just look at your fluoroscopy and see where your probe is going. Yeah. Okay, so pick your segment. So you're going to pick where Jackie's balloon is. Yeah. Yeah. This is basal segments, huh? Yeah. Lateral and posterior. Yeah, take from either the lateral or posterior segments. Yeah.
Let me just press the balloon.
Yeah, so you're going to make sure you can see the tip of the balloon. Yeah, like here is good. Now inflate it there. Good, good. Yeah. Good. Can you see that? That's the bronchus.
This the whole segment.
Yeah.
That's fine.
That's what I like, yeah.
I like that too.
Now, yeah. Now you see, you can see the tip of your balloon. So you know which bronchus you're going to occlude. Yeah, you can inflate it again, you just check. Good. Now you see, it's a little deeper. If you want to occlude this one as well, then, yeah, see, you'll do it like that. So,
I'll go lateral.
yeah, so it's really a team effort. Yeah, you have to do it. So now, Andrew, you can pick the segments based on what you include. Yeah.
I'll go lateral.
Yeah.
I'll go here.
Good. So when you're ready, ask for the probe. Yeah. It's okay. Just follow when the probe comes out of the end. Then use fluoroscopy now. And that's why I like the continuous setting, because it makes it easier for me. Yeah.
First flip it.
Okay. Now I'm going lateral.
Oh, okay.
I decided to go lateral.
Yeah. So you have to make sure the balloon doesn't go too deep.
Okay.
Others.
All right. So continue.
Yeah. Step on the pedal. Good. Now you can see where the tip is. Yeah. Now what I want you to do is, can you feel resistance?
Yeah, it's already.
Now pull back 2 centimeters. Yeah.
Okay,
Good.
good.
Not yeah, but just 2 centimeters. Good. Yeah. You can take it a bit from. That's okay. Yeah, that's fine. That gray area between the 2 ribs, that's a good spot. Now, what I want you to do is, you hold that nicely like that. Now you don't have to hold that with your hand. Hold the scope here. All right. Now, focus on the pedal. When you're ready, start to freeze. And then I want you to really just jerk it out quickly. Okay?
1,000, 2,000.
So go for 4 seconds and out. Excellent. Jackie, you've got the balloon. Andrew, put it in here. Release the pedal. Good. Now, actually you can do it from your end. So you've taken the sample. Okay, I think we've got enough tissue there.
I think just the thing of coordinating the.
Yeah.
I hope you didn't toss out the.
No, it's there. Okay. Good. Take out the cryo probe. Yeah, give it to probe out. Jackie, you've got the balloon in place. Now you're going to go back in quickly, check for bleeding. Yeah. And you see, look, that's not badly placed. Now suction. Yeah, good. Good. Deflate your balloon a bit. Watch for about 2 seconds. There.
Yeah, this is right.
Yeah, and that's why you see the blocker placement is very important. Yeah, that's why we're very particular on where we place it and how we place it.
Now I'm getting the gist of it. Let me
Yeah.
go for another.
How many have you got? 5. Okay, we can take one more. 6 is the maximum we should take.
I've understood what you meant with the continuous cryo.
The fluoro. Jackie, you see your balloon is perfect. That's how it's supposed to be. Yeah. You can pick your segment. If you can get the side one, well and good. Yeah, good. Now fluoro. As soon as it's out, you can't see the tip. It has to be fluoro. Yeah. Now come back. Yeah, that's okay, Andrew. Yeah. That's fine. Yeah, that's good. That's okay. Good. Now hold it nicely. Good. Other hand down there. And freeze 4 seconds.
1,000, 2,000, 3,000, 4,000.
Out. Good. And don't release that pedal. When you did your first one, I stepped on your foot. So that you don't release the specimen. Yeah.
That's good. That's good habit. That's a good habit.
You can release it now once it's in the water. Yeah.
So that it thaws.
Yeah, because we want it to thaw in there. Okay, good.
Thank you, guys.
All right. Probe out. You now, if there's bleeding, I'm leaving. You're going to sort it out. See you guys tomorrow.
That's what used to happen to the boss. You say that.
Good.
So I think we should get our
Yeah, you're actually abutting the balloon. Yeah. Now you can release, observe, and usually it's good. Wait for about a minute, because you don't want to have bleeding later and then you're stuck. So just.
So I think the last one
No. And you see, we like biopsying. Yeah.
I like going down.
So this is good, yeah.
Do you want me to remove the balloon now?
Yeah, I think there's no. You can inspect, make sure you're okay. Okay, you're good. We're done. Yeah, Andrew.
Yeah, I'm happy. I'm happy. The bleeding is minimal.
We're doing another one Monday.
You're good.
Okay.
No, I mean, I've done like 3.
And after all, you can't do.
Thank you, guys.
You can't.
You need another person.
Let's make sure there's no air.
It looks good.
Unlock the floor for me for a second. What I usually do is get an apple from my sheet. Okay, check.
But even this one is very well. So far, so good. It looks.
Yeah. Yeah, we are good.
Okay, we're good. No new
We are good. Yeah.
Sheila, so we're done.
Thank you, Tim.
Thank you so much.
So thank you, Tim. Yeah, tutakuita Monday tunayo kama uko area kuja. So that one you just do it. Yote. Oh. Oh, okay.
We'll come out at 060.
You want to take a picture?
Celebrity status.
Yeah.
Oh, where you're so small, but it's almost
Ah, yangu ni mzuri. But I think the size went well. Are we done with the video?
So we can do it
We do it outside? Yeah. Andrew, come.
But they're fun. They're fun, but you sweat. Wow, we just died the last one.
Yeah, I want them to see a doctor.
Yeah.
Then I can start advertising for patients.